Okay, now we want to talk about root canal preparation. Okay, root canal preparation. So our major goal is the prevention of the periauricular disease and or promotion of the healing in cases where disease already exists. Okay, so we don't want the let's say periauricular disease to extend to further. So what are the major techniques? Let's say techniques, we can have the manual preparation, we have the machine-driven, sonic, ultrasonic preparation, and laser systems. What majority nowadays is used in the clinics is the manual preparation and the machine-driven. The only thing I think machine-driven is not used as much is the cost-wise for the dentists. So Schilder described 5 design objectives. He said that the funnel tapering from it should be from the apex to the axis cavity. The cross-sectional diameter should be narrower apically. As you know, if this is the, let's say, canal, okay, let's say this is the apical, let's say apex, whatever. So while we're doing the endo treatment, so first we'll go with the full length. So like our master file, I've talking about this in our previous videos. So, but I'm just gonna say a little here again. So like for example, let's say this is our master file, which is usually 25 to 30 depending on the canal. I mean the size of the file. So, and then after that we reduce it. So the next one, so when we turn into the blue or green and black, so when we turn into these, we reduce the size. So for example, let's say the length was, I don't know, for example, 21 millimeters in our master file, but when we turn to blue, we go 1 to 2 millimeters smaller. Okay, so we won't go in 21 millimeters to our full length. We'll go, I don't know, 19 millimeters, and then here again another less, so like 18 millimeters, and then here again 17 millimeters. Okay, that's why here what Schilder was saying is that the cross-sectional diameter should be narrow apically. This meaning, so like it's like thinner here and then gets like, you know, wider and wider, because these black, green, and blue are wider than, for example, red, that we went to full length of the root canal. Now, third objective is that the root canal preparation should flow with the original shape of the canal. So like if it's like this, we're not supposed to go in like this, or I don't know, like this, or make a turn, you know? Makes sense. Fourth objective is that the apical foramen should remain in original position, meaning that we shouldn't make another opening here, for example, or here. So where it is, it should remain there. Fifth objective is the apical foramen should be kept as small. That is because we don't want the overflow of the material through the apex. It's like it will be a both-way canal. If we widen it too much, bacteria can come, fluid can come inside, and the same wise the root canal materials that we use for filling could just overflow. So there are 4 biological objectives that we have to consider. First one is that removal of all tissue from root canal space. It has to be a confinement of the instrumentation to the roots themselves. No forcing of the necrotic debris beyond the foramen. So while we're doing the root canal, we shouldn't be keep pushing if there's any, you know, necrotic debris. And also creating sufficient space for the intracanal medicaments. Okay, so these are the 4 biological objectives that we have to respect. Now, going on to techniques. There are 2 types of techniques that we can do while doing the manual. Here we have the manual preparation. First one is the apical to coronal, meaning what I just explained here. So like we go first from the apex and then moving on to the coronal, meaning what? First we'll go with the smallest file we have all the way to the full length, so we will find the working length. For example, we start with white, and then we will go to yellow file, which is 20, and then we'll also go full length. So what we're doing is that we're cleaning first the apex, So after we reach the master file, which is a, for example, rep file, let's say, we will reach the full length, and then we will go up. We will prepare again, as I said here. So this is exactly, this technique that I explained here is exactly applicable to coronal, okay? So it's a conventional, step back, modified step back. These are what it's called. This is step back is where we would switch to the blue, to 1 to 2 millimeters smaller than the master file with blue, green, and black color. Now, coronal apical is the other way around. So like they start preparing first from the beginning, going on to the apex. Some believe that this is better because in this technique we're basically pushing all the not clean, let's say debris or whatever to the apex, because it's, you know, we're pushing it like bacteria. But with coronal apical, you're cleaning out little by little, and once you reach the apex, there's minimal bacterial leakage. Some believe this, but majority this apical coronal technique is used. Okay, you see, instrument pushes apically during rotations about 45 degrees angle. First, we'll explain the apical corona or step back technique. So it has two phases. So phase one, we have the apical preparation, as I said. So see, with file, we go all the way. So like, let's say 25 is our master file, okay? So we have to enlarge it at least 3 sizes. So for example, when you start with white, then you go to yellow and then red. Okay, so that was phase one. So why do we need to have at least 3 sizes? Why do we need to approach 3 sizes? It's because we need to remove the bacteria, we need to remove the dead pulp tissue, we need to increase root canal capacity, and also prepare the root to receive the canal feeling. And why are we increasing the root canal capacity? Why do we need to do that? So the advantages of doing that is that we will have a proper apical stop, and there will be less chances of apical transportation. And the disadvantages of this is that the debris can block the canal, loss of the working length, and time, and it's usually time consuming. Okay, now going to phase two of the step back technique. Here we have to increase the size while decreasing the length. So this is where the step back begins. So until here we went with our master file to the full length of the canal. Here when we go to phase two, so let's say we started cleaning the root. We started with our first file, second file, and our master file, which is our third file. After that, that is where step back starts. Here we need to reduce 1 to 2 millimeters from our master file. So see, so by using 30, 35, and 40, okay, again, like you see here. I already explained it above here, not going to explain it again here. I already explained it to you guys over here. So we're actually creating a coronal taper, okay? Now, so there's a recapitulation. So in between the master files is inserted to the working length. This is important. So what is this? So after we did this and we went to phase two, every time we want to change from one file to another one, we always have to use the master file again. So basically it's just to make sure that we still have our full length and there's no blockage, okay? And irrigation again is very important. Between every file you need to irrigate actively, okay? So like up and down movements of the syringe. Now there are these, let's say, phases 2A. So complete the apical preparation by enlargement of canal using Gates Glidden. You can also do that. So you can see here, by using the Gates Glidden, we use it to complete the preparation. And then we have phase 2B, which we use the Hedstrom file to flare the apical part. So this is at the end basically, because we want to allow the adequate amount of the coronal space in root for lateral compaction. So you know that Hedstrom files have are special files with special, let's say, spiky ends that it basically smoothens out the root for the final filling. Now moving on to coronal apical or the step down technique. Here we have we reduce the chances of the post-operative discomfort and increase in the healing time. Why? As I told you before, because basically with the step down we are eliminating the bacteria that could reach the apex. Okay. So what you do is that you fill the canal with irrigants, and then with headstrom file, you penetrate. So using the circular. So headstrom is the one with the circle sign. Okay, we go 15, 20, 25 to the full length, all three. Okay, and then in the coronal third, flared with gates, glit, and drill, we flare it, and then recapitulate with the first file to prevent the blockage. Okay, every time, as I said, also it's as here. The advantages of this is because we will have a straight apical access, eliminates coronal interferences, removes bulk of the tissue and microorganisms before apical shaping, allows deeper penetration of irrigants, and less amount of necrotic debris could be excreted through the apex. And what are the disadvantages? It's more time consuming, it may weaken the tooth, and it's less flexible rotary instruments are used. Okay, now we'll move on to the balanced force technique. So what we do in this technique is that we use blunt tipped files, which are also called flexophiles. Instruments are guided by the canal walls. So they place the file to the length and then a clockwise rotation, less than 180 degrees. And then followed by an anti-clockwise rotation, which is at least 120 degrees with apical pressure. So a heavy pressure requires large instruments, and the light pressure, we do it with the small instruments. So what you do is that first, when you get into a canal, you have to go first clockwise. Clockwise, less than 180 degrees, okay? And then, at the same time, you do an anti-clockwise for 120 degrees. So, like, these type of movements, like this, and then from here again, like, okay, less, like, okay, so, like, let's say 180 degrees like this, and then 120, like, somewhere around here like this. So, like, you do these type of movements. Let me draw it. So, like this, and then again the same here, just less. That's the type of pressure you do. Okay, the advantages of this is that there's less chance of canal transportation, and there will be no blockage, and also less material extrusion. Okay, now going on to the rotary endo, usually we use nickel titanium. The files are nickel titanium, and the advantages is that it cleans out the root canal very smoothly. Trust me, it's like removing butter, like putting butter on the bread. It's so smooth, so easy. It's very reliable, and it's super faster. Not only doing the instrumentation is faster, but filling up the canal, because in this type we use the one cone technique. Let's say you just apply majority of the time. You just put one cone gutta perca, and it fills up the canal perfectly. And it's usually more comfortable for the patient because we're decreasing the chair time. Okay, errors can be the canal blockage, ledge formation, and instrument separation, which this is basically every dentist's nightmare. With blocked canals, compacted dentinal mud, residual pulp tissue, remnants of the filling materials, these could be what can be causing the blockage of the canal. Okay, and with this, usually you just have to go with a smaller file to make an entrance again, or just try to either bring out the blocked debris, which usually is not that possible, but usually we just have to push it through the apex. Now with the ledge formation, so what is a ledge? Ledge is that when you go here, you can see in the picture over here, when it goes away from the direction of the apex. Okay, there are some deviations from the normal canal anatomy, as you can see here in the photo, because of transport. They're called transportation, zip, elbow, and so yeah, that's about this today. Please like and subscribe us, and let me know in the comments if you want to know more information about any other topics.